Namaskar, dear students and young intensivists and other colleagues who have joined in. So today for our critical care webinars under the aegis of young Indian intensivists, we are going to be talking about spine trauma, and we'll try to cover neurogenic shock, which is generally part of spine trauma but can occur in other conditions also. So we have distinguished faculty today. Our faculty today is Professor Niraj Kumar. So sir is in All India Institute of Medical Sciences, Department of Neuroanesthesia and Neurocritical Care. He's also involved with the same department in the trauma center related to AIIMS. And his area of interest is spinal cord injury, amongst other things. And he's the director of various courses, and he has more than 100 publications to his name. So it shall be very interesting to learn from him, and I think it'll be a very nice webinar that you're going to have. So over to you, Dr. Neeraj Kumar sir.
Thank you, Dr. Tapesh. So, good evening, everyone. Today we are going to understand the very important but very challenging topic, that is spinal cord injury, and especially the unique feature of cervical spinal cord injury is neurogenic shock. So, I'm sharing my slides. Visible?
Yeah, visible.
Okay. So, uh, I'm starting with the case scenarios. Uh, A 26-year-old male suffered from motor vehicle accident. He is conscious, oriented, unable to follow commands. This patient came to the casualty, and vitals in the casualty is blood pressure 84 by 60, heart rate is 55, respiratory rate is 30 per minute, and breathing is labored, and he is not able to move his forelimbs. So this is the typical case of cervical spine cord injury we are receiving in the casualty in any hospitals. So we can see that he is conscious oriented and able to follow commands. That means the head injuries component is unlikely. And when we see the vitals, the blood pressure is 84 by 60. That means the patient is in hypotension and it is in shock. And heart rate is 55 per minute. That means he's also having bradycardia. And regarding respiratory parameter, we can see that that is 30 per minute. That means he's in tachypnea. Breathing is labored. That means there is a problem in the respiration. And he's not able to move four limbs. That means there is a quadriplegia. So if we look closely, that is a unique feature. This is hypotension, bradycardia, tachypnea, problem in the respiration, and there is a quadriplegia. So all the features are suggestive of upper level, most probably cervical level of a spine injury. So this is a typical scenario we are receiving in the casualties. We will see in a stepwise manner how we should approach such patient to manage uh, and prevention of secondary spine injury. So objective of this talk would be, first of all, we will discuss something about the neuroanatomy and the pathophysiology of the spine injury. Then the unique feature, that is neurogenic shock. We will little bit discuss this feature in detail. And overall management. Overall management starts with the immobilization of the cervical spine. Then, for any trauma patient, we have to approach like doing primary survey. That means the stabilization of the airway, breathing, circulation, and disability part. And then we will move further to go for the definitive management. So we will move stepwise manner. So first of all, this spinal cord injury is the most devastating kind of injury for all trauma events, and it has a profound effect or profound impact on physical, psychological well-being of the patients, and it poses a significant financial burden not only to the patient families but the total healthcare system of our country. Regarding epidemiology, this is the incidence is varies globally across all the places. But regarding US data, there is 55 new cases per million people annually, and this is approximately 12,000 new cases per year. And most commonly, the young male, that is the age between 15 to 35 years of age, is commonly involved. But the old age is also affected when we consider the fall from the height. Regarding the mechanism of injury, there are several causes for the injury, but the motor vehicle accidents and fall from height constitute the most common cause of spinal cord injury. Other causes are violence-related sports injury, like diving or skiing, firearm, gunshot injury, and others. The most common injury is a motor vehicle accident and fall from height. Regarding the neuroanatomical, we will discuss a little bit the autonomic nervous system, and that is sympathetic and parasympathetic nervous system, because this is the most commonly involved. And understanding the pathophysiology and neuroanatomy is very, very important for cervical spine cord injury. So we this thing we all know from the very beginning. This is just basic that sympathetic nervous system is for flight response, and in response to stress to our body, it increases heart rate, it constricts blood vessels, and it is responsible for increasing the blood pressure. And origin, we all know that is a thoracolumbar origin, that is from T1 to L2 vertebra. While parasympathetic nervous system is responsible for rest and digest system, and on the contrary of the sympathetic nervous system, it causes a decrease in the heart rate, and it dilates the blood vessels. And we all know the origin is from the craniosacral origin. The cranial nerves are 3, 7, 9, 10. The vagus nerve is very, very important for the parasympathetic nervous, and from S2 to S4 nerve segment is also the origin of the parasympathetic nerve. But we have to remember that the vagus nerve is very, very important for our this cervical injury component. So there, the vasomotor center is situated in the medulla, that is the brain stem, and from that place, that is also called a supraspinal center. And this send activator impulses through the descendant pathway to the sympathetic preganglion neurons in the thoracolumbar region. So this concept is very, very important to understand. Again, I am repeating. The supraspinal center, that is the vasomotor center, that is situated in the medulla of the brain stem. They send the activator impulses through the descendant pathways to the sympathetic preganglion neurons, and uh, they the important tracts of this descendant pathway are reticulospinal and raphospinal tract. The main function is to control the heart rate and blood pressure. So the preganglion, regarding sympathetic nervous system, we have seen that the descendant pathway from the supraspinal center terminates into the preganglionic neuron. Now the preganglionic neurons from the thoracolumbar regions emerges through the ventral root, and that synapse to the postganglion neuron that are situated in the paravertebral sympathetic chain. So it is the sympathetic chain where the preganglionic neurons synapse with the postganglion neurons, and now the postganglionic neurons emerges from this sympathetic chain, and uh, they uh, they uh, they are synapse with the heart and blood vessels. So that is the story of the sympathetic nervous system, whereas the parasympathetic nervous system, the preganglion neurons are located in the cranial nerve nuclei, that is the 3, 7, 9, 10 uh, of the cranial nerve that is situated in the brain stem. And the preganglionic fiber synapse with the postganglionic neurons near the myocardium. Then no involvement of the sympathetic chain. They directly inserted in the myocardium. And there is no parasympathetic outflow to the peripheral vessels. So the sympathetic involves the sympathetic chain present in the spinal column, whereas the main parasympathetic, that is the vagus nerve, directly is supplied to the heart. So they know in no parasympathetic involvement in the thoraco or cervicothoracic spine. Regarding pathophysiology, we have to understand that the primary injury and the secondary injury concept of any spine trauma. So the primary injury, we have to understand that that is mainly because of the mechanical forces applied to the at the time of accident. So whatever the injury occurs at the time of accident because of mechanical forces, the impact to the body or cervical spine, that is the primary injury. And whatever the injury occurs after the primary injury, that is because of inflammation or ischemia, free radical formation or lipid peroxidation. After the primary injury, whatever the changes occurs during the course of time, that is the secondary injury. So primary injury refers to the actual mechanical or tissue damage immediately at the point of injury, whereas the secondary injury initiated within the minutes after the primary injury. And it is because of inflammation, immune changes in the free radical formation. So that is the concept. But we have to understand that we cannot do anything about the primary injury. Primary injury has already occurred. Now the secondary injury starts, and our aim is to prevent this secondary injury. We cannot do anything about the primary injury. So we have to understand that we as a doctor or medical professional, we our aim is to prevent the further injury. That is the prevention of the secondary injury is our aim. So we will gradually moving forward. We have understand the basics of neuroanatomy and the pathophysiological aspect, and gradually we are moving forward. That is, like the patient has come to our casualty, and we are managing such patient in a stepwise manner. So any trauma patient, we have to follow that the primary survey is very very important for any trauma patient. That is the airway breathing circulation part has to be stabilized first. Then as the patient is hemodynamically stable, then we have to move to the next step. So the aim in such patient, we have already discussed that aim is the prevention of secondary injury. So technically, we have to maintain the vascular perfusion and oxygen delivery to the injured spinal cord. That is the main goal or main aim of our management. And we have to reduce the secondary damage to the cord, and we have to and how it can be done, we have to restore the blood pressure and the heart rate to a safe range, because we our fear is that there might be the spinal cord ischemia and the further neurological damage. So we have to prevent the hypotension and bradycardia and hypoxia naturally to prevent the secondary damage. So this is the basic aim: prevention of hypotension, prevention of hypoxia at every step. So the management is naturally a multidisciplinary approach with many stakeholders are involved here, like the critical care physician, the neuro surgeon, the anesthetist, the neuroradiologist, the neurosurgeon, the acute care physician. the orthopedic surgeon, later on there is might be the psychological involvement. That means the psychotherapist is also has an important role. So this is the a whole team has to be involved if we want the patient, if we want a better patient outcome in such patients. So this is, remember, this is the multidisciplinary approach. So the management protocol starts with the spine immobilization. Then after that, we have to take care of the airway, breathing, circulation, and to that we have to go for the fluid resuscitation. Then vasopressors have also important role for for maintaining the blood pressure. If there's a bradycardia, the atropine is also important here. Then we will move forward for the definitive surgical decompression. So, spine, don't forget about the spine immobilization. So, why this spine immobilization is important? Because it has been seen that during the handling of such patient, uh, about 5 to 10% increase in the neurological injury because of improper immobilization. So, the goal of immobilization is to prevent further injury caused by the spine motion. So, the standard method of immobilization is the using the whole body, and the neck should be in the neutral position, first of all, and the patient should be placed in a long spine board, and the spine, this cervical collar should also be applied, and the head is immobilized by using the bolster devices, and the whole body should be wrapped in a tape, and the straps should be applied to the whole body. So immobilization is important to prevent further injury. And after that, we have to do the quick primary survey in which we have to take care of the airway, breathing, and circulation. So regarding airway, if naturally, as the patient comes to you in the casualty, you have to attach all the monitors and see the vitals and give the external source of oxygen. And even after giving the oxygen, if the patient saturation is not improving, and as in we have already seen in our case that there is a labored breathing, there is a tachypnea, there is falling the saturation. So you have to take a decision to intubate such patient if there is a danger of hypoxia. So airway management is not simple here. This is the category of the difficult airway management, and as the same as we are managing the airway, we have to take care of this spine immobilization also. We cannot afford the too much movement of the cervical spine because it may cause further injury. So, so there is a concept of manual inline stabilization. So it is commonly practiced during intubation. So when we have decided to intubate such patient, so naturally, if the cervical collar is already in place, that makes the intubation very difficult. So it is suggested that you remove the anterior part of the collar and apply the manual inline stabilization. If you are intubating yourself, then ask your assistant to apply the manual inline stabilization. And then, if you have already intubated the patient and your tube is in the right place, that is in the trachea, and you are seeing the its confirmation in the capnography. Now you can remove the mills and reapply the interior part of the collar. So this is the commonly practiced strategy for intubating a patient with suspected cervical spine injury. And so this MILS, and that means the manual inline stabilization is very, very important because we cannot afford this movement of the cervical spine. So, so one thing also important that during the airway management, generally we manage with a triple maneuver, that is the head tilt, chin lift, and a jaw thrust. So this triple maneuver is cannot be applied while managing the airway for the cervical injury patient, because if you do head tilt and chin lift, that that is very dangerous to the cervical spine. So you can only use this jaw thrust if you are suspecting cervical. So remember, this head tilt and chin lift is contraindicated while managing the airway of such patient. You can use this jaw thrust maneuver. So regarding intubation, which instrument is best, which technique is best is the debatable topic. But grossly, we have three options like direct laryngoscopy, video laryngoscopy, and awake fiber optic intubation. So if you are in a casualty, that means direct laryngoscopy and video laryngoscopy is the good option for you. And if in the casualty, uh, you have to intubate such patient in an emergency condition as the SpO2 is falling. So awake fiber optic is not indicated in such patient. Awake fiber optic is excellent tool for elective cases and if the patient is cooperative. So every instrument has its pros and cons. Like with the direct laryngoscopy, it's very very simple and easy, and it is quickly available all the places. But the downside is it causes some cervical spine movement that is not good for the patient, and the visualization of the glottis is also not good if the mills is applied. Whereas the video laryngoscope copy is a very fantastic instrument as it improves the laryngoscopy view. But the downside is if there is too much of the blood secretion, it the visualization might be difficult. While awake fiber optic is excellent for the elective situation and if the patient is cooperative, and you can also document the neurological examination with that. And it is said that the movement of cervical spine is least with the awake fiber optic. But for using aware fiber optic intubation, it requires the significant amount of expertise. And if there is too much of the blood and secretion in the airway, that is also the downside for the using awake fiber optic intubation. So what I suggest that the video laryngoscopy has overall good instrument for intubating such patients. Regarding breathing and ventilation aspect, that is very interesting facts because if we have to divide the cervical spine in the upper part, middle part, and the lower part. The upper part is C1 to C3, and if that is injured, there is a complete paralysis of the diaphragm. We have to understand that the diaphragm is the main muscles of inspiration, and that is supplied by the phrenic nerve. That is the origin from the C3 and C4 and C5. So naturally, if the injury is C1 to C3, the phrenic nerve is totally paralyzed, and diaphragm is not functioning at all. So such patients uh, we have to intubate and put the patient in the mechanical ventilation. Regarding this middle part, that is the injury if, at the level of C3 to C5, there is a varied impairment of the phrenic nerve and the diaphragm. Regarding this lower spinal injury, that is the C6 to C8, although the phrenic nerve is intact, so diaphragm muscle is also intact, but the other abdominal muscles are paralyzed. That is also not good. The abdominal muscle has a very, very important role. As we can see that with the abdominal muscle is paralyzed, there is a decrease in the maximum expiratory force. So there is a reduced ability to cough out the secretions and the protection of air. That may lead to atelectasis, ventilation perfusion mismatch, and later on it may lead to respiratory failure also. So that may create a vicious cycle. That we have to understand that abdominal muscle is also very, very important for not for the inspiration, but for coughing out the secretions. So what we have to do regarding the respiratory management. So as the patient in the casualty, you have to monitor the patient. If the patient is in respiratory failure or not. If the patient is stable, note down the respiratory parameters and observe and note down the parameters serially and give the supplemental oxygen because we have to prevent the hypoxia. Hypoxia is the very damaging to the spine cord. Uh, so regarding this cardiovascular involvement, so this is a leading cause of morbidity and mortality both in the acute and the chronic stages of the spinal cord injury. And the severity depends upon the level of injury and the degree of injury. Level of injury we have already discussed, the upper level, middle level, or lower level. As the level is higher, the severity of the consequences is also higher. Similarly, if the degree of injuries is, if it is complete injury, that means there are total loss of all the function below the level of injury, that is responsible for the poor prognosis of such patient. Whether if the injury is incomplete, that is comparatively a better prognosis than the complete injury. So remember, any kind of consequences depends upon the level of the injury and the severity of the injury. So, regarding the cardiovascular complication at the acute stage, in initial phase, we are worried about the spinal shock and the neurogenic shock. In the chronic stages, there is a special complication that is autonomic reflexia, and patient also might develop at the coronary artery disease, atherosclerosis, the later stage in the chronic stages. The most important complication in the acute stage is neurogenic shock. In the chronic stage is the autonomic reflexia. Neurogenic shock we will discuss in the coming slides. But remember this the cardiac arrhythmias, the bradycardia arrest may occur at both acute stages and the chronic stages. So this the disruption of the descendant pathways, that is from the supraspinal center to which is present at the medulla, to this the preganglion neurons of the thoracospine region, the descendant pathway from the supraspinal center to this thoracolumbar spine is called descendant pathway. And at the cervical spine injury, this the damage or disruption is the main pathological culprit for all the consequences. So always remember this feature, that is disruption of the descendant pathways leads to uh, the the damage to the circuit, and this circuit unable to generate the sympathetic activity. So now there is a connection from the supraspinal center to the sympathetic neurons is lost because of that injury. Now there is a lack of sympathetic tone or activity that may lead to the vasodilatation. Moreover, we all know that the parasympathetic is supplied by the vagus nerve, and vagus nerve is not passing through this pathway. This is the vagus nerve is directly from the from the cranium supplying to the heart. So that is intact. So there is loss of sympathetic activity and vasodilatation. And because of this parasympathetic activity is intact and if vagus nerve is intact, there is a bradycardia. So that is the main the pathophysiology we have to understand. Because of cervical spine injury, there is a problem in the sympathetic supply. And sympathetics, there is a loss. Whereas the parasympathetic activity is intact. So in fact, there is overactivity. So the main crux of the matter is the loss of sympathetic and there is a parasympathetic overactivity. That is the main the physiology we have to understand. So because of loss of sympathetic activity, there is a peripheral vasodilatation and there's a pooling of blood, and that may lead to the decrease in the venous return and the preload, and as a consequence, there is a decrease in the stroke volume and the cardiac output. That is the main cause of hypotension. Okay, so there are two terminologies. One is spinal shock, and one is neurogenic shock. So remember, spinal shock is a neurogenic phenomenon, and neurogenic shock is the hemodynamic phenomenon. So many people confuse at this point. I want to clear that a spinal shock means loss of function below the level of injury. That is neurological function loss. That is the sensory loss, there is a motor function loss, and the loss of reflexes. This has nothing to do with the hemodynamics. Whereas the neurogenic shock is a purely a hemodynamic phenomenon. Hemodynamic phenomena means hypotension and bradycardia. So, neurogenic shock is the characteristic feature of a cervical spinal cord injury that is characterized by the hypotension and the bradycardia. We have already discussed the main pathophysiology is the loss of sympathetic activity, which leads to vasodilatation, peripheral pooling of blood, decrease in the venous return, decrease in the preload, decrease in the cardiac output. And we have already seen that the parasympathetic is intact. That means the vagus nerve is intact. So that the vagus nerve is causing bradycardia. There is a simple pathophysiology. Hypotension and the bradycardia is the unique feature seen in such kind of patients, which is not seen in any category of other kind of shock or other kind of patient. So hypotension and the bradycardia is the unique and hallmark feature of this neurogenic shock seen in this upper level of thoracic or cervical spine injury patient. So we have to remember that although the neurogenic shock is the characteristic feature, so that has to be differentiated from the hypovolemic or hemorrhagic shock. So remember, we are managing a trauma patient. Although our patient is the spine trauma or cervical spine trauma, this is a trauma patient. So we have to understand that the hypovolemic shock or hemorrhagic shock is the main or the most common shock which is seen in the any trauma patient. So hypovolemic shock is the characterized by hypotension and tachycardia. We all know that. We have already seen that neurogenic shock is hypotension and bradycardia. So we can clearly differentiate between the neurogenic and hypovolemic shock. That is, the neurogenic shock is hypotension and bradycardia, or hypovolemic shock is hypotension and tachycardia. Moreover, the feature regarding skin is in the neurogenic shock, the skin is warm and dry. Okay, because there is no blood loss. Whereas in the hypovolemic shock, because of hemorrhage, the skin may be cold and clammy. That is also another differentiating feature. So this is very, very important. And we have to remember that while managing the patient in the casualty, many times it had been seen that both the hypovolemic shock or hemorrhagic shock is also associated with the neurogenic shock. So the management of hemorrhagic shock is the fluid resuscitation and the blood transfusion. We have to remember that it may not be the case that neurogenic shock is present in isolation. It may be possible that both the shock is present in the same patient. We have to understand that. Regarding this, bradycardia is also a unique feature. Many times, or most commonly, we have seen that the heart rate is below 60. around 50 it is commonly seen. So that is the feature which differentiate it from the hypovolemic shock. Hypovolemic shock we see tachycardia or bradycardia in such kind of patient is a very unique feature. And most commonly it is seen in the acute phases. The incidence is around 64 to 77%. Moreover, we have to also understand the aggravating factors for the bradycardia. Like we are doing tracheal suctioning, we are doing laryngoscopy and endotracheal intubation, and this the stimulating things causes vagal reflex, and it aggravates tachycardia and this bradycardia. So hypoxia is also another aggravating factor we have to remember. So whenever we are managing such patient, we have to keep in mind that if you are doing suctioning or intubation, the atropine should be ready. So if there is the severe bradycardia, we can immediately infuse atropine. So remember that the patient is characterized by the hypotension and bradycardia, and we cannot afford the lower amount of blood pressure for such patient. Anyhow, we have to increase the pressure to increase the spine cord perfusion so that we can prevent this secondary spinal cord injury. So, management of the cardiovascular system starts with the fluid resuscitation. So, first line of management in the circulation part is uh, to maintain U volume. Okay, that means the filling the tank part or the filling the vascular system. So we have to insert two large bore IV cannula and give 1 to 2 liter of fluid as the initial part of fluid resuscitation. So this point we have to also understand that we cannot give too much amount of fluid. We have to avoid fluid overload. So after achieving the euvolemia, we have given the initial amount of fluid as a part of fluid resuscitation, and we assess whether our CVP or any the euvolemia is achieved. If the blood pressure is still low after fluid resuscitation, we cannot give too much amount of fluid. We have to remember this because the fluid overload may lead to pulmonary edema and other fluid related complications. Because we have to remember that there is sympathetic loss and the heart is weak because sympathetic supply to the heart from the T1 to T4 segment is compromised. So heart is weak in terms of contractility. If we give too much amount of fluid, that may lead to pulmonary edema. So even after fluid resuscitation, if the blood pressure is low, we have to move to our the second choice of drugs, that is vasopressor. So vasopressor is very important as a second line therapy after fluid resuscitation. So there is a consensus from the American College of Neurosurgeons that the goal is to maintain the mean arterial pressure around 85 to 90 mm of Ag for the initial uh, 7 days. That goal we have to remember. That is, studies have shown to improve the outcome of such patient. If we maintain the mean arterial pressure around 85 to 90 mm Ag is in the first week of the injury. So we have to use vasopressors. So we have to understand that there is a problem in the vessel, like there is a vasodilatation and there is a problem in the bradycardia. So we have to use an agent having both the alpha agonistic activity and the beta agonistic activity. So ideal agent is norepinephrine and dopamine, having both alpha activity and the beta activity. Remember, regarding phenylephrine has only the alpha activity and no beta activity. So if we use phenylephrine, there are chances that the bradycardia worsens. So remember, the norepinephrine and the dopamine is the drug of choice here because it had both the alpha agonistic activity that causes vasoconstriction and the beta agonistic activity that causes the increase in the contractility of such patients. Regarding the if we have managed the cervical spine primary survey and we have stabilized the airway, breathing, and circulation, then we do secondary survey, and here we do complete neurological examination. We take complete history. After the secondary survey, we have to remove the spine bone. Remember now, as the patient is stabilized, at the last part of the neurological examination, we log roll the patient, and after doing the spinal examination, remove the spine board because spine board may lead to the pressure ulcer formation if we use for a long term. And after that, till the time we have suspected that patient might having the cervical spine injury, and we have managed the patient accordingly. Now it is time to clear the cervical spine, whether it is actually present or not. And we can do either by the clinical examination or the radiological examination. So there are certain clinical decision rules that are very, very popular. If the like this is the nexus criteria that is very, very popular. So this has a five component, and that is the if the patient has a normal level of alertness, if there is no evidence of intoxication, if there is absence of this posterior midline tenderness, if there is no focal neurological deficit, and the fifth point, if there is no dystactic injuries like long bone fractures, large laceration, or degloving injuries, or large burns, if the these five criteria are not present in the patient clinically, then there is no need of radiological examination. So patient can be cleared his cervical spine or her cervical spines on the basis of only clinical features. The advantage is that we can prevent this X-ray exposure to the patient. So remember, we have cleared the cervical spine either by the clinically or by radiological. If the clinically the patient is not fit for this examination, then we have to go for the radiological examination. Regarding the radiological, we can use either X-ray, three views, AP, lateral, and open mouth odontoid view, or the most useful is CT scan. So it has been shown that the primary mode of the radiological examinations would be the CT. If the CT is not available in the center, then the X-ray, AP, lateral, and open mouth odontoid view can also be done. But a CT should be the primary method of ruling out the cervical spine injury. If the CT facility is available in the hospital. So, regarding the further definitive management, there's a stepwise manner. If the patient is stable, in the left side, we can see that if the patient is stable, if there's a minor spinal fracture, then no neurological deficit, the patient can be managed on the OPD based, and simple analysis and follow-up is what is required. But if the patient is unstable, hospital admission and a spine surgery consultation is required. If there is a multi-system trauma involved, then it is preferred to admit the patient in the ICU. If the spine surgical consultation or neurosurgical consultation is not available in the center, then we have to consider the transfer of such patient to the higher center where the spine surgeon consultation is available. Now, the initial part of management is we have completed. One important concept, that is autonomic dysreflexia, is also important and unique feature of the spine trauma. So we are discussing that. Remember, this is a chronic complication. It is not seen commonly in the acute phase, but it is commonly seen in the chronic phase of spinal trauma. And it may be potentially a life-threatening condition. Most commonly, it is seen above the level of the T6 injury. So remember, as in the diagram, that there is a level that is T6. If there is a sympathetic activity below the level of injury and parasympathetic overactivity above the level of injury, that is the main pathophysiological understanding regarding the autonomic dysreflexia. So, if there is noxious stimuli that triggers the reflex below the level of the injury. The most common noxious stimuli are the full bladder, full bowel, or so. The characteristic feature is the vicious cycle. That is the sympathetic response below the level of injury and uh, the increased parasympathetic response above the level of injury. So the and for the pathophysiological understanding, uh, there is the noxious stimuli below the level of injury, like bladder and bowel distension, that leads to the sympathetic surge. That is the sudden and uncontrolled activation of the sympathetic nervous system and the after this sympathetic response below the T6 injury, the brain response is the brain receives the signal of that stimulus, and naturally, if there is a sympathetic response, there is the huge hypertension. The brain senses it, then brain tries to control this hypertension. That sends the parasympathetic activity, but this parasympathetic activity cannot pass below the T6 injury. So above the T6, there is a parasympathetic activity. So there is a parasympathetic activity above the level of injury that may lead to the bradycardia and vasodilatation above the level of the injury, that is flushing and sweating. So, we have for better understanding. So consider the features below the level of injury and above the level of the injury. So above the level of injury, we have seen there is a parasympathetic overactivity. So there is a vasodilatation. Because of vasodilatation, there is a severe headache, profuse sweating, flushing of the skin, and nasal congestion of bradycardia. And below the level of injury, because of the noxious stimuli, we have already seen there is sympathetic overactivity. Goose warmth, pale, and clammy skin is seen. So the high blood pressure is a characteristic feature of autonomic dysreflexia because of the sympathetic overactivity. So uh, uh, if it is untreated, the severe hypertension can lead to the complication like a stroke, seizure activity, myocardial infarction, or death. So, regarding the management, first of all, we have to make the patient upright so the blood pressure is a little bit on the lower side. And you have to identify and remove the trigger. We have already discussed the most important trigger is a fluid bladder and a fluid blood bowel. So this trigger is important. You have to identify and remove the trigger. So we have almost completed our the interesting but challenging cervical spine cord injury. The unique feature of this injury is neurogenic shock. We have now we are summarizing this talk. So we first of all for we have to suspect that any patient coming in the casualty, especially in the multi-system trauma and the severe mechanism of injury, we have to suspect that cervical spine injury may be present. and we have to protect cervical spine. So immediately we have to apply the cervical immobilization, and, and that should be applied until the cervical spine injury is ruled out, either by the clinical examination or the radiological examinations. So immobilization is very important to prevent further injury. And we have to use the long spine board, cervical collar, the bolster devices, and the strapping is the standard method of immobilization. After that, the primary survey and the stabilization of the patient regarding airway, breathing, circulation, and disability is our first priority. And we have to stabilize the patient hemodynamically uh, because hemodynamically patient is might be compromised, like if the in our case, if there is a problem in the respiration, like tachypnea, breathing is difficult, labored breathing, SpO2 is falling, they have to intubate such patient. So intubation might be difficult. We have to remember that we have to, during intubation also, we have to protect the cervical spine by applying the manual inline stabilization. And the phrenic nerve is maybe injured, so we have to remember that the phrenic nerve is the main muscle of respiration. So might patient may need a long-term ventilatory support. And regarding the circulation part, we have to understand that there is a sympathetic loss and there is just parasympathetic activity. Because of sympathetic loss, there is a vasodilatation and the hypotension. And because of parasympathetic overactivity, there is a bradycardia. So this unique feature, hypotension and the bradycardia, is the neurogenic shock. That is the unique feature seen in such patient, and we have to differentiate it with the hypovolemic shock, which is characterized by the hypotension and tachycardia. So we have to put two large bore IV cannula and fluid resuscitation. We have to provide fluid resuscitation as the first line of management, but we have to avoid fluid overload, and we have to use the vasopressors if the blood pressure is not increasing. So vasopressor is choice is noradrenaline and dopamine, because we want both alpha and beta activity. And as our primary survey and secondary survey is completed, we have to remove the spine board as soon as possible, because we want to prevent the pressure sore formation. And at that point, we have to rule out the cervical spine injury either by the clinical nexus criteria, or we have to go for the CT or radiological examination. CT is preferred compared to the X-ray examination if CT facilities available in the center. After that, we have to consult with the spine surgeon. If the spine surgeon is not available in the hospital, we have to consider transferring such patient to the higher center where such facility is available. And regarding these steroids, it has been shown that there is no enough evidence for using steroids to improve the outcome. So there is a consensus that the steroid is not recommended for such patient to improve the outcome. So thank you.
Thanks, sir, for a wonderful talk. Just close the screen, share. Yeah.
Yes,
So
please.
I request the audience, if they have any questions, please type the questions. Meanwhile, I can just put up a few points, sir. So you talked about
Yes,
the hypertensive crisis because of noxious stimuli.
yes, yes,
So why this
yes, yes.
stimuli leads to hypertensive crisis in spinal cord injury? Because over full bladder, etc., is seen in normal patients also.
So to understand this, we have to see the complication in the acute part and the chronic part. In the acute stage, there is a neurogenic shock, that is hypotension and bradycardia. Uh, hypertension, that is a part of autonomic dysreflexia that is seen in the chronic stage of the cervical injury. Hypertension is not seen in the acute stage. Acute stage is hypotension and bradycardia, that is neurogenic shock. So in the chronic stage, there is a unique feature that is autonomic dysreflexia, and that is characterized by the severe hypertension. The chronic stage means around 6 weeks. You can understand around autonomic dysreflexia is in around a 6 weeks interval. So that is characterized by the hypertension. So what happens that patient is very sensitive at that stage. So because of full bladder and the this constipation or the fecal impaction, there the this sympathetic response goes to the spinal cord, and since the because of injury that response is uninhibited. Normally this response is inhibited by the supraspinal center, but because of the injury at the T6 level or above, T6 or above level, this hypertension brain senses and send the parasympathetic activity to counter that hypertension. But because there is a because of injury, the parasympathetic response or the inhibitory response does not able to travel the lower part of the injury. So in the lower part of injury, there is a sympathetic response. In the upper part, there is parasympathetic response. That is the main reason for the hypertension or sympathetic activity in the lower part of the spine injury.
Thank
Yes,
you.
Tapas.
Thank you, sir. So then about the presence of neurogenic shock. So it occurs
Yes.
typically below T6.
No, injury, if the injury is above T6.
Yeah, above T6.
Yes, hypotension, or that means neurogenic shock you are talking about, is most commonly seen in the upper cervical injury and upper thoracic injury. This is hypotension and bradycardia seen in the acute part of the injury, that is the neurogenic shock, and mostly seen in the cervical injury and upper thoracic injury.
So why T6 is taken as cutoff?
Because we have to understand that the basic one-liner which I have already described in the talk, that because this upper thoracic or cervical injury, there is the sympathetic loss. This we have to understand. Because sympathetic loss, because we have to understand that sympathetic supply is from thoracolumbar, that is from T1 to L2. Moreover, the heart is supplied by the T1 to T4. So that is lost in if the injury is above T1. Okay, because sympathetic supply through the heart is T1 to T4. If the injury is above T1, that means sympathetic supply is lost. So when sympathetic supply is lost, heart is not able to contract properly. That is one reason. Second reason is sympathetic supply is important for vasoconstriction. So if there is a loss in sympathetic activity because of injury, there is a vasodilatation. So there are two reasons: vasodilatation, the pooling of blood, decrease in the venous return, decrease in the cardiac output. That is one factor. The second factor is because the direct supply from the T1 to T4 to the heart is lost, there is a decrease in the contractility also. So both the things, decrease in the preload, decrease in the contractility, both the things leads to decrease in the cardiac output and decrease in the hypotension. We are talking about a neurogenic shock in the acute phase. That is the main pathophysiology.
Yes, sir. I appreciate that, sir. There are two factors. One is the heart, and one is the vasomotor tone to the vessels. But if it is lower down, the heart will not be
Exactly.
affected. But there's so much of vasculature. For example, abdominal vasculature. Supposing it's lower down, the lower than T4, T5, then heart will not be affected. But the abdominal blood vessels will vasodilate. Will that not lead to shock?
So in the lower part of the injury, actually you are absolutely right. The heart is not affected. The one factor is not affected. And moreover, the supply of the blood vasculature is through the sympathetic. So as we move down, the vasculature part is not too much affected.
Okay, sir.
Okay, so there is not too much of vasodilators, although that is affected. We are totally agree with that, but effect is not that much that causes a severe kind of thing. So in the lower part of the thoracic injury, the heart is not affected at all. Little bit of vasodilatation is observed, and that in that case we can use phenylephrine also, because only component that is affected is vasculature, and phenylephrine is sufficient to counter that. That means the phenylephrine has only alpha activity. So in the lower part of the thoracic injury, little bit of hypotension is seen because of little bit of vasodilatation, and in that particular segment of the patient, we can use phenylephrine also.
Right, sir. So then, what is the natural course of this neurogenic shock in such cases when it occurs? How long it persists and
Okay, right. Right, right. So neurogenic shock is a characteristic feature we have already discussed, that is characterized by hypotension and bradycardia because loss of sympathetic activity and overactivity of the parasympathetic nerve. So mostly it is seen in the acute phase. Acute phase means it is seen it is seen around first week to 4 to 6 week. Okay, mostly first month or 4 weeks. It can be seen up to 6 weeks also, but most commonly it is seen till fourth week or first month of the injury.
right, sir. So supposing in the initial stages the patient does not have hypotension, that is neurogenic shock, and these patients stay in the ICU for a long time. Is it possible that let's
Right.
say for 1 week patient is going to hypotension and sometimes you're not sure, is this possible? This is happening due to neurogenic shock?
So, uh, uh, remember, most in the acute phase, we have already discussed that acute phase, neurogenic shock is seen around 4 weeks, till 4 weeks, you can say, or it may be up to 6 weeks also. In during this period, if there is a hypotension and there is a patient having bradycardia, most commonly it is because of this neurogenic shock. But before declaring that patient is in neurogenic shock, we have to rule out hypovolemic shock or hemorrhagic shock. Okay, so that's why it is not necessary that patient neurogenic shock come in isolation. Many times it comes with there is a mixture of neurogenic and hypovolemic shock. That's why he that's why hemorrhagic shock management and ruling out the patient is hypovolemia is very, very important. That's why the management initially this fluid resuscitation. So even after, if patient is in hypovolemic shock, then fluid resuscitation should improve the blood pressure. So even after doing fluid resuscitation, if the patient is not improving, that means that hypotension is not because of hypovolemic shock. Or we can also utilize this fast examination, that is the focused assessment of trauma so external source of hemorrhage we can see externally, and for every trauma patient we do fast examination to rule out the internal source of bleeding. So if the past examination is also negative and we are not seeing externally the blood loss, so so after fluid resuscitation, if the hypovolemia is ruled out and the patient is still hypotension, most probably it is because of neurogenic shock. And in the casualty, if we are managing such patient by giving fluid resuscitation and giving the vasopressor like noradrenaline, and such patient immediately taken into the neuro ICU, and we have to use this noradrenaline or dopamine for around months. Okay, so gradually that the severity of neurogenic shock decreases during the 2 week or 3 week or 4 week. Till that time, what we do in our ICU, we put a central line. Okay, we put a either the this internal jugular or subclavian vein, and we infuse our this inotrope vasopressor through that central line. So this is a very common practice in our ISU. Such patient of the cervical spine injury, we are admitting such patient in neuro ICU. Patient have the lower blood pressure and the bradycardia. We will see that the heart rate is around 50. That is very common feature in our neuro ICU. And remember, we have to maintain the mean arterial pressure around 85. So that is a little bit of higher side to maintain the spinal cord perfusion. That is our main aim. So that is our practice. That this is most commonly seen in first week, 2 week, or 3 week, or 4 week, and gradually the severity of the hypotension is decreases gradually, and we as the blood pressure improves, we gradually wean off this the pressure support from the patient.
Thank you, sir.
Right.
So then about this thing, gastric ulceration, stress ulceration, there's increased incidence and there has to be proper
Yes, yes.
preference.
Yes, you are right. That is the gastric ulcer formation is the common feature in every ICU, and such patients also vulnerable to that. And the whatever the management for a general patient, that is also applied to this category of the patient also.
And even the DVT prophylaxis is very important because they are quadriplegic, many
Yeah.
of them paraplegic, quadriplegic.
That is, yeah, yes, Tapat. That is, you have raised a very important issue. We know that patient is quadriplegic or paraplegic. That means that there is no limb movement, and such patient, or moreover, there is no movement, and there is a vasodilatation. That means there is a venous stasis also. This venous stasis and there is no movement. That is the main factor for increasing the chances of thrombosis. You are absolutely right. So these patients are very vulnerable for the thrombus formation. So as soon as we can do thromboprophylaxis, we we apply the thromboprophylaxis either with non-pharmacological method or with pharmacological method, as discussed with our neurosurgeon. And you are absolutely right. That such patients are vulnerable because of the paralysis and the pooling of blood. So thromboprophylaxis is the must for any admitted patient.
So what is your usual practice for thromboprophylaxis in these patients?
Yeah, absolutely. So we have just I have mentioned that there is a non-pharmacological method and a pharmacological method. Regarding this non-pharmacological method, there is a
DVT
we
pump.
use this DVT pump we use, and also we have some special devices also. Regarding this pharmacological low molecular weight heparin, we can utilize that also. But we have to discuss with the surgeon if there is a plan of surgery. We can avoid using pharmacological or low molecular weight heparin if there is the plan for the surgery. So grossly we have two methods, non-pharmacological and a pharmacological method. Regarding non-pharmacological method, we use DVT pumps, and pharmacological method we use low molecular weight heparin. Yes,
Thank you. So final point about the respiration. So obviously the
right.
phrenic nerve is involved, like you cervical injury, high cervical injury. Obviously, there's a problem. But even if if it's below C5, you get the
Yeah,
involvement in the thoracic nerves, which involve
yes,
the intercostal muscles. So is there a
right.
problem in weaning these patients because of involvement of these intercostal muscles? Even if the
Yes, Tapas.
even if the diaphragm is spread, you feel there's a problem in weaning these patients?
Yes, Tapas, you have raised a very important questions, and very important issue regarding this management of such patient. So, if you understand the respiratory pathophysiology, the main muscle of respiration is diaphragm. If the diaphragm, the supply is by phrenic nerve, then that is C3, C4, and C5. So if the cervical spine injury, if there is an involvement of this phrenic nerve, that means the diaphragm will be paralyzed. So that is the very severe condition. So most of the time, such patients are ventilatory dependent. But even if the diaphragm is not paralyzed, like in the lower part of the injury, which you want to discuss, the injury is at the lower level, the phrenic nerve is intact, the diaphragm is functioning. But if the abdominal muscles is paralyzed, so we have to understand the function of the abdominal muscle, the main rectus abdominis and these accessory muscles of the intercostal muscle. That is also very, very important role in our respiratory system. As we know that the rectus abdominis or the abdominal muscle are very, very important for expiration or coughing out the secretion. As our patient is or in our ICU is ventilatory dependent, if the patient is not able to cough out the secretion, there is accumulation of the secretion. Okay. Later on, slowly it may lead to ventilation perfusion mismatch, and it may lead to ARDS as the day progresses, and respiratory failure may be seen if it is not managed properly. So the ICU care is very, very important. The nursing care, whatever the secretion is coming out, how how is the nursing care secretion is removed from the patient. And moreover, the most important role is physiotherapy. So we have, I've already mentioned this is uh, multi-team approach. So physiotherapy's role is very, very important. So, as the muscles are weak, patient is not able to cough out the secretion. So, physiotherapy, a strong physiotherapy is very important to not only to removing the secretion. We have also our cough assist device also. We have there is a cough assist device
Yes,
also.
yes, yes.
Uh, so we are using in our ISO. I will that is very, very useful. I will recommend everyone to use that device in their ICU also. So moreover, that helps in cupping out the secretion. That will help in prevention of respiratory failure in a long term as a part of long term management of the
Right,
respiratory
sir, right.
system.
Thank you, Professor Neeraj Kumar, sir. Very nice and very educative. I'm sure our audience, which is joined in large numbers, will also find it very useful. So we shall put
Uh,
it up on our YouTube channel in the coming weeks after just editing it a little, so the entire, community of intensivists and maybe neurologists and anesthesiologists can all review it. Thank you so much, sir. Thank you. And I thank the audience for
Thank
joining
you.
in. Thank you, everybody. Bye bye.
Thank you, audience.